to the staging and assessment of resectability of pancreatic tumors, that makes my task a lot easier to talk about imaging of response to therapy. So we know that imaging allows us to stratify patients for management. And you heard the use of MRI or CT enables us to select patients for surgery, in that if we are able to identify patients who are resectable, we can, in an MDT setting, offer these findings to the surgeon and make a joint decision for surgery. And we also know that even with successful surgery, if the patients are fit enough, many of them will then receive adjuvant chemotherapy. Now, in the borderline resectable group, patients are often offered in an MDT setting neoadjuvant treatment before further decision of surgery. And in the locally advanced setting, or unresectable tumors, patients are also often in the MDT setting often a trial of chemotherapy or chemoradiation treatment. Now, what is common to all these patient pathways is that chemotherapy appears to be the key. And the chemotherapy regimes in pancreatic cancer has evolved over time, such that now, if you read the literature, what has really transformed and influenced the outcome of patients with pancreatic cancer is the use of FOLFIRINOX chemotherapy, and we'll discuss why that is so. Now, in the patients who are thought to be resectable, these patients are offered primary surgery. And just as a reminder, these are patients who have a small confined tumor that has no evidence of any vasculature involvement. So in these patients, once the surgery has been performed, they are offered chemotherapy. And for a long time, it was unclear whether such treatment is of any major benefit. And this is a study that was presented at ASCO this year by Thierry Conroy and his associates in the Prodigy trial, where they used FOLFIRINOX chemotherapy compared with standard gemcitabine treatment, and they were able to show that patients had better median disease-free survival, overall survival, time to metastases with FOLFIRINOX chemotherapy compared with gemcitabine therapy. Although the problem here is that FOLFIRINOX chemotherapy is often more toxic, and therefore some patients may withdraw from that treatment or do not complete the chemotherapy treatment. Now, in the borderline resectable group, and we have heard about the criteria of borderline resectability, so I won't go through that. So the idea of neoadjuvant treatment is to potentially downstage the tumor to maximize any potential for tumor margin-free surgical resection. It also affords an opportunity to treat micrometastases. And also, in the neoadjuvant setting, where the patients are often a little bit fitter, therapy with chemotherapy is better tolerated. So there are many meta-analyses out there in the published literature, and we're just taking one example here as an illustration. So this was a meta-analysis looking at 18 studies with 952 patients by Tang et al., published in Pancreatology in 2015. And they were able to show that using neoadjuvant chemotherapy, either alone or in combination with radiotherapy, and you can see that at least 4 of these studies used FOLFIRINOX treatment, they were able to achieve complete response in 3% of the patients, partial response in about 30%, but a large number of patients show stable disease by conventional size measurement criteria. Progressive disease was observed in about 17%. But what is interesting about this series is that about 65% of patients went on to achieve successful resection, and the number of tumor margin-free resection, or R0 resection, was almost 60%. So In terms of patients with locally advanced tumor, the treatment has become really quite aggressive as well, in that many of these patients are also offered a trial of chemotherapy treatment. And one study, this was published in Annals of Surgery last year, in 575 patients, showed that if you administer FOLFIRINOX treatment in even patients who are locally advanced, you can achieve successful surgical resection in up to about half the patient, and about 61% of these was achieved after FOLFIRINOX chemotherapy. And the survival of patients in this group was also better. So therefore, the challenge we have is that how are we going to image patients after neoadjuvant or trial of chemotherapy in patients who are borderline, resectable, or locally advanced? And how are we able to use imaging to predict the likelihood of a tumor-free resection margin? So here we have a middle-aged man with a locally advanced cancer. You can see a long segment of involvement of the SMV, and in fact, it was completely stenosed. And you can see a long cover tissue abutting the SMA vessel. And here's a picture of MRI of the same patient after neoadjuvant treatment. And you can see that there's reconstitution of the SMV and also shrinkage of tumor from the SMA. And this patient went on to achieve a tumor-free resection. So the question often asked is, how are we able to assess the potential of surgery after chemoradiation or chemotherapy treatment? And as it turns out, unfortunately, it seems that we're not very good at this. So there are not many papers out there, but this is a paper that was published by Kasinoto's group in radiology in 2014, and they look at reassessment of response with CT after neoadjuvant treatment and radiation therapy. And what the group found was that if you see certain features in the patient after neoadjuvant treatment, they were associated with pathological response at histopathology. So a 4 in the CA99 level was correlated with a good pathological response, but it's important to remember that the CA99 levels is not raised in about 10% of patients, and it is unuseful in patients with biliary obstruction with raised bilirubin levels. Post-treatment diameters, not surprisingly, if the tumor shrinks significantly, it is often associated with response, but there's a problem that many patients in this category may not show a change in tumor size despite pathological regression. They have also shown that a change in the SMV, portovenous contact, is associated with good pathological response or a regression of the tumor from the SMA. These were found to be significant findings. Now, what about prediction for a tumor-free resection margin, or R0 resection? It would appear that if you see tumor initially in contact with the vein and then regressing from the vein, it has a very high positive predictive value, and partial regression from any peri-pancreatic vasculature has also a high predictive value for able to clear the margin from these venous axes. However, it was also very interesting that the prediction of R1 resection was relatively poor. That is to say that even if you see soft tissue persisting at the site of previous disease, it is not predictive of R1 surgical resection. So another example here, now on CT, we show a large tumor in the pancreatic neck region before therapy and after therapy. And again, this patient, you can see because of the regression of the tumor from the vein, you can see now quite a clear fat plane between the tumor and the vascular structure, allowing you to have confidence that this has responded to treatment and surgical resection is possible. So unlike in the primary tumor staging, imaging following neoadjuvant treatment tends to underestimate pathological response and overestimate vascular involvement after neoadjuvant chemotherapy. And we know RECIST, unfortunately, is not very helpful because tumors may remain very much the same size despite a good pathological response. And we know that, therefore, ability to predict resectability is relatively low after neoadjuvant treatment. So on a practical level, if you have a patient with borderline resectable pancreatic adenocarcinoma after neoadjuvant treatment, how do we think about decision-making? Well, in the MDT setting, normally if a patient shows stable or no change, it will be discussed extensively at the MDT, and surgery is often considered. If there is a clear response, these patients are usually triaged for surgery, and if the patient progresses after chemotherapy, then usually surgery is not offered. Now, the scenario with the locally advanced disease is less clear, and that decision-making really depends on your local setting, your surgeon experience, and also what the culture or the thinking of the MDT group is. So the locally advanced group, the practice or the treatment or the management of this group is very much dependent on local practices. Now, eventually, many of these patients go on to develop metastatic disease. And I come back to FOLFIRINOX again. This was the paper by Thierry Conroy's group again, published in the New England Journal of Medicine in 2011. And they were able to show that even in metastatic disease, if you administer FOLFIRINOX treatment over standard chemotherapy or gemcitabine, you are able to extend patient survival, median survival of 11 months compared with 6.8 months. Progression-free survival that was longer, 6.4 versus 3.3 months, and a higher objective response rate. Again, because the FOLFIRINOX treatment is more toxic, there were more adverse events or adverse drug reaction observed in the FOLFIRINOX group. Now, when it comes to assessing treatment response in the metastatic setting, and indeed in the neoadjuvant setting, size measurement is still useful to some extent if you see tumor size shrinkage, such as administering the RECIST 1.1 size measurement criteria. And we've seen that actually the problem is that the size measurement response criteria does not predict resectability, pathological outcome, or downstaging, and it is relatively insensitive to early treatment effects. So Amer et al. Published last year in January in this year, January in Cancer, and they were looking at a new way of assessing CT images, looking at the interface of the tumor between the tumor and the normal pancreatic parenchyma. So just by way of an illustration here, so here we have two tumors in the pancreatic head. In the first example on the right, you can see that the tumor becoming much more well-defined after therapy, and they call this a type 1 response. And the second example below, you can see this pancreatic head tumor becoming very much less well-defined after treatment, and they call this a type 2 response. And the assessment of size was independent, so there was no independent assessment of size in this study. And they went on to study the categorization of type 1 versus type 2 response in 4 different cohorts of patients, 3 retrospective cohort and 1 prospective cohort. And the first cohort is in patients with early tumor, second cohort in metastatic setting, third cohort in a trial setting in patients using a very specific neoadjuvant gemcitabine treatment. And this is a prospective study where they were looking at early stage pancreatic cancer who are receiving neoadjuvant treatment on the prospective registry trial. And what is compelling about their data is that if you look at patient survival, whether you have a type 1 versus type 2 response, is that patients with type 1 response appear to consistently across all cohort perform better in terms of survival compared with those with type 2 response. Clearly, this is very early work, and it needs to be validated by other experience. So there is also an opportunity to use PET imaging as a way of assessing response. And in our institution, we rarely use PET imaging as a means of assessing local disease response or metastatic response. But clearly, there is compelling evidence that metabolic response has been also shown to correlate with pathological response and also disease survival. Now, I just wanted to, in the last few minutes, look at some of the ongoing works of looking at novel imaging for assessing early or subtle tumor response. So we know that studies have shown in perfusion imaging that if you have tumors with higher flow or K-trans value, these patients appear to respond better to chemotherapy agents, and this may be due to the ability to deliver drugs to the pancreatic tumor. And this observation was also translated to this study in MRI, where again, they showed that responders had higher K-trans and K-ap values compared with non-responders. Now, using diffusion-weighted imaging, these Japanese co-authors were able to show, and here on the y-axis is the progression rate, and on the x-axis the number of days. And it was shown that patients with higher ADC had lower progression rate compared with those with lower ADC. And one of the proposed mechanism for that was that we know that pancreatic tumors are often very fibrous and very serous, and that translates to the low ADC measurement that is measured, and therefore it's a matter of the difficulty of the proposed mechanism is that there may be difficulty for the drug to actually penetrate into the tumor, leading to chemo resistance. This study by Dr. Monia Bali and authors using ADC histogram showed that they were able to use this sort of histogram information to categorize response much more earlier and more accurately than using RECIST criteria. And last but not least, just to mention what might be on the horizon, these are preclinical studies looking at MR elastography as an imaging technique. And we know that pancreatic tumors are very stiff because of the serous collagen that is within the tumor. And in this example, you can see that by using MR elastography, you can create you can measure the degree of stiffness of the vessel and see how that is able to be modulated and change in response to drug therapy. In this example, these mice were given a vascular disrupting agent that effectively starved blood flow to the tumor, causing necrosis. And you can see that there is a reduction in the stiffness and viscosity of the tumor after drug administration. And the reason why it is maybe important is that stromal disrupting effects of some of the existing chemotherapy are well described, such as nab-paclitaxel. And you can see that after nab-paclitaxel, in this example of a photomicrograph, you can see breaking down of the collagen bundles within the tumor stroma. And indeed, there are now new agents that are coming out into experimental testing that specifically target the tumor stroma within pancreatic tumor. So in summary, I hope that I've shown you in that short time that FOLFIRINOX chemotherapy improves patient outcome in the adjuvant, neoadjuvant, or palliative setting, that in the neoadjuvant setting, conventional imaging underestimates pathological response and overestimates local disease extent, and that the limitations of RECIST should be appreciated as newer criteria are being evaluated to improve patient stratification. Thank you for your attention.
Thank you very much, Mood, for this comprehensive